Cannulas of cardiopulmonary bypass. The cannula of the cardiopulmonary bypass circuit include arterial cannula, venous cannula, antegrade and retrograde cardioplegia cannula, left ventricular veins, pulmonary artery veins, and aortic root veins. The perfusionist requires a certain size of cannula to achieve the certain flows that need by the patient without exceeding pressure gradients. Formula for selection of cannula. Details of patient's height and weight are necessary to calculate the ideal flow rate by calculate the body surface area first. BSA can calculate by this equation body surface area in square meter, which is required to determine the ideal flow rate at the normothermia. Blood flow is equal to BSA into cardiac index, and so to select the appropriately sized venous and arterial cannula and oxygenator. As shown in figure, this is formula for BSA calculation. Arterial cannulation, proximal aorta, distal to the cross clamp, femoral artery, axillary aorta, distal aorta. Venous cannulation, right atrium, vena cava, femoral vein. Cardioplegia cannulation, proximal aorta, proximal to the cross clamp, coronary sinus, coronary ostia, by graft during CABG. Cannulation sites shown in figure. Arterial cannula. The cannula should provide adequate flow without an excessive pressure gradient across the cannula. The size of arterial cannula have been determined by the flow and measurement of pressure drop. The pressure drop is the difference between the pressure entering the cannula and that leaves pressure in the aorta. Shows high resistance across the cannula cause an increase in pressure drop. Pressure gradient over 100 Hg are associated with excessive hemolysis. Insertion of cannula into the aorta, as shown in this figure. Cannula misdirected in B and cannula is correct in C period. Some cannulas have right angle tip to insertion into ascending aorta. Some have straight tip to minimize resistance or to peripheral insertion. right angle aortic cannula are shown in this figure. Complications of aortic cannula: inability to inserting the cannula, including cannula interference by the advancia, fibrosis of aortic wall through small incision. Air embolism from the cannula to the circuit, obstruction of the aorta in infants, inadequate size leading to high pressure and low flow generation. Peripheral cannulation: peripheral cannula incision into femoral artery or femoral vein for minimal invasive cardiac surgery, extracorporeal membrane occlusion, ECMO. Femoral aortic cannulas. Complications of peripheral cannulation: trauma to cannulated vessel, thrombosis or embolism, hemorrhage, distal ischemia, infection. Causes of aortic cannula: high pressure, kink in aortic cannula or line, cannula improperly positioned, cannula too small, arterial systemic pressure is very high, aortic dissection, class clamp to near of cannula. Venous cannulation. Venous cannula flows. Draining is usually accomplished by gravity. The amount of venous drain is determined by the central venous pressure, patient's blood volume, the difference in the level of the patient and top of the blood level in the venous reservoir, and the resistance in the venous cannula, venous line, and connectors. Venous cannula: two-stage venous cannula, single-stage venous cannula, right angle venous cannula. Different types of venous cannula. The most common used is two-stage venous cannula. It has open tip that is placed in inferior vena cava and more proximal opening that will be located in the right atrium. Two-stage venous cannula as shown in this figure. The other method of venous cannulation is with two single-stage cannula. One is placed in the superior vena cava and the other in inferior vena cava. These are connected to common venous line with a Y connector. Bicaval cannulation shown in this figure and other two-stage cannulation are shown in this figure. Femoral cannulation, femoral venous cannulation are rarely able to support full flows on bypass. It used to support circulation until cardiac exposure is achieved and central cannulation is possible. Superior vena cava or right atrium cannula can add to the femoral venous circuit to allow for full flow on bypass. Femoral venous cannulas are shown in figure. Complications of venous cannulation: low cardiac output due to retraction of the heart during IVC Perfusion suture placement, air embolism, especially if the arterial pressure is low, displacement of the central venous catheter during inserting the SVC cannula. Malposition of cannula tip including inserting the SVC cannula into the agarus vein, inserting the SVC cannula into the innominate vein, inserting the IVC cannula into the hepatic vein, inserting the RA cannula into the LA across an arterial septal defect. Causes of forced venous return during CPB: inadequate size of cannula, inadequate venous pressure, kink in circuit with obstruction of line, airlock in the venous line or cannula, oxygenator or venous reservoir is not positioned low enough, inadequate height of the patient above CPB venous reservoir, venous cannula placed into forward one or up, and vena cava not draining. Cardioplegia cannula. Retrograde cardioplegia is the most common technique of giving cardioplegia to the heart via the coronary sinus in the reverse direction of normal blood flow. Retrograde cardioplegia cannula incision shown in this figure. The cannula is placed into the coronary sinus through the right atrium. The cannula has a balloon near the tip that, when inflated, prevents the flow of cardioplegia back into the right atrium. The cannula are two basic types, either automatic or manual bearing inflation. It is required to inflate the cuff using an included syringe before delivering cardioplegia. Antegrade cardioplegia cannula are designed to deliver cardioplegia solution in the aortic root or directly into the coronary ostia in normal direction of blood flow. Antegrade cardioplegia cannula initiation as shown in this figure. Aortic root cannula used to infuse cardioplegia directly into the aortic root near the aortic wall. It has a short needle tip that is placed into the aorta. The aortic wall and aortic crossclamp prevent the flow in either direction and thus force the cardioplegia into the coronary arteries. This cannula come in various sizes and with various lengths or checked without vent line to accommodate various techniques. Coronary perfusion cannula is placed in the coronary ostia when need to give cardioplegia directly into the coronary ostia. This cannula come in various sizes and different configurations. Coronary perfusion cannula There are two common designs of coronary perfusion cannula. The small hand-held cannula with a soft tip that is placed over the coronary ostia, and the cone-tipped cannula with self-inflating balloon that inserts direct into the coronary ostia. These cannulas are used when aortic root is open. Example: aortic valve replacement. Arterial cannulation insertion as shown in figure. Venting of heart. The pump circuit allows to level the blood from the operative field to be returned to the circuit via the reservoir. Venting cannula as shown here. Venting the heart during CPD prevent leaking from the heart, reduce myocardial rewarming, improve surgical exposure, evacuate air from the cardiac chamber during the dearing phase of procedure, create a dry surgical field, especially during the digital coronary anastomosis phase of CABG surgery. The most common site of cannula place is dedicated vein, the aortic root, the right superior pulmonary vein, the left ventricular apex, pulmonary artery, the left atrium, or the left ventricle. Complications of venting: damage to the LV wall due to excessive suction, LV wall rupture if inadequately closed at the end of bypass period. Like, share, please do subscribe. Perfusion Talks.